We're going to talk today about advanced care planning and how we need to manage that in Epic. This is a subject that many patients probably have not considered, particularly if they're in good health and not elderly. But this is something that everyone should think about from time to time, and if possible, have documentation in Epic, in the system, that gives advice to providers in the hospital, in the emergency department, maybe even in the clinics, about how to manage the extent of care provided to patients. And so we're going to talk about that sort of planning, what documentation can be done, what we should be doing to discuss these things with patients. So, Irma, do you want to show us how this works?
Yes, okay. I'm gonna go ahead and share my screen. Dr. Schumann, can you confirm you could see my screen?
Yes, there it is.
Okay. So once you go into the chart, whether the patient is there for a walk-in or an appointment, if we haven't addressed this in the calendar year, there is an OPA you will see, which is a no ACP OPA, which starts for patients for 18 to 64. Um, This OPA is to be addressed by medical assistants. It's basically some questions. So this will be more of an MA workflow, not provider. When it does become a provider workflow, it's for our patients who are 65 and older. For patients who are 65 and older, the advanced care planning will be a care gap. So for the care gap, if you click directly on it, what it will do is prompt you to basically help you place orders for code statuses. It is recommended to utilize a smart set that is built for providers to quickly assess advanced care planning. So if you go to your plan tab or with our upgrade, it will be called a this visit tab, and you type out ACP. The smart set for advanced care planning will populate. You will go ahead and then click on open the smart set. And this smart set will nicely guide you with some suggested diagnoses. And if for say the patient does not want to discuss and they decline, that the diagnosis is there too. And any action that you take here will address this care gap. You have some codes here that you can drop if you discuss advanced care planning with the patient and for the first 30 minutes. And there are some orders for you to place if the patient does know or wants to make a decision on what kind of code status they like. A referral is embedded here, and also a note to quickly help you document if the discussion of advanced care planning.
I'll comment on that. For most patients, I suspect, other than elderly patients who are infirm, um, this is a decision, a discussion that can be difficult. I think the decision to whether or not to be resuscitated, the extent of post-resuscitative care, really ends up in many cases being related to what the patient's state of health is, what the likelihood of the patient's condition will be post-resuscitation if occurs. And when a patient's healthy, it's hard to know what decisions to be made. Also, the family members or others uh, often would want to have a decision here. So if the patient knows that they, for whatever reason, they don't want to be resuscitated, or they always do want to be resuscitated, then one of these selections could be made. Otherwise, if the patient's uncertain, wants to think about it, wants to talk to the family, this sort of decision can be delayed, and we can proceed to documenting that. And Irma, you can suggest how that happens.
Mhm. Okay. So if the patient does not have a decision for the code yet, that is perfectly fine. The medical assistants should be handing out forms, which is an advanced care packet, which will describe all this for them and explain on how this process works. So they should be handing that out. What the provide as a provider, what you can do is go ahead and place the diagnosis that it was discussed. Um, Check off your that you discussed this with them, and utilize the advanced care planning note to document that you discussed this with the patient. Now, recommended workflow within Epic is you should document your advanced care planning note separate from your actual office visit note or annual. So basically, what you would do is click accept on your main note. And then after you do your selections, let's say I did discuss it, it took 30 minutes. The patient does not have a decision yet for their code status, but I do want to document a note that I discussed this with them. I'd go ahead and choose my selections and then click sign. And that will go ahead and drop my diagnoses. Oh, what did it do? Did it add it on here? Did not add my note. And it should have added my note, but for some reason it didn't. Let me go ahead and click. That one looks completely different from the one we were using. Give me a quick second.
Let's do this. Let me
Yeah, pause it.
pause it. Okay, in about 2 seconds, go ahead.
Okay. So if the patient does not have a code status they want to input, that is perfectly fine. But we did discuss the advanced care planning with them. You can go ahead and make your selections, whether they declined it or you did discuss it. And you can also add your CPT code if you spent your for the first 30 minutes. The patient does not have a code, which is perfectly fine. But we do want to make sure that we make a note about it. One key note is for you to understand for us as for providers is we want to make sure this documentation is separate from your actual visit note. So basically, if you have your standard note here, whether it's a walk-in or your IHA, you want to make sure you close that so you can go ahead and create a separate note just specifically for advanced care planning. So since I made my selections in the smart set, I could go ahead and click sign and it will go ahead and open up my advanced care planning note, which is this here. Um, you will go ahead and use your three asterisks, as we all know, is and for us to embed a free text field. So I could put I spent 30 minutes and you would go ahead and answer the smart lists. So if there was any family present, you could go ahead and add that. So if it was the patient and the spouse, and it is multiple select. So let's say it was the patient and the spouse for this scenario. And if we already added a surrogate decision maker, for the surrogate decision maker, it is an OPA, which is MA facing. So the MAs do get prompted once the patient is 65 to enter a surrogate decision maker. So this should already be added there. The surrogate decision maker is in the ACP activity. So you can go ahead and find that there and then just free text it. If they still have not made that decision, you can always use it to be determined. And if we initiated any forms, we can go ahead and put here if we gave any of these. For our clinics, we mostly carry the advanced care directives that CCH recommends. So we could use that, but the patient can use any of these. And if we completed any of the forms during this session, you could go ahead and document that as well. For this time, I'm going to just put none, and then I have completely successfully documented my advanced care planning note. After that, I could go ahead and choose any of these options. For this scenario, I'm just going to put I want it to be signed when I sign the visit, and then I could go back to my standard note and complete my office visit documentation.
And then is that all that the provider needs to do at this point in this
Yes.
topic?
Yes. The provider utilized the smart set and it dropped down the advanced care planning diagnosis. And we also chose for the CPT code that we spent 30 minutes discussing this with them. In the back end, it will drop an additional CPT code if we filled out the surrogate decision maker on top of us making this advanced care planning note. So all the extra charges will be automatically dropped once they sign the note.
What happens in 3 years, 2 years when the patient decides that they were married, now they're divorced, so they don't want the spouse to be a decision maker, or they now they've got a terminal illness and they know that they don't want to be resuscitated when before they did. How does that change occur?
So for that change, if they need to make any changes to to their surrogate decision maker, they can go to that advanced care planning activity. The quickest way to access that activity is within the storyboard where it says code not on file, or if there's one on file, you could just go ahead and click on that section and it'll take you to the advanced care planning activity. Within this activity, if the patient had a surrogate decision maker already on file, you can always go ahead and edit those. So if there was one on file, you can go ahead and inactivate it or delete it and then add the new one. If they had a terminal illness, then that's when you would go ahead and actually activate the surrogate decision maker. So we would address any decisions to them. Um, and if they decided to change their code status, then we would just update a new code status here, and then we would make a new ACP note about the changes.
Okay, that sounds good. And for providers dealing with this, I think that we would want to emphasize to the patient that this is not a permanent designation or advice. It can be flexible depending upon what the patient's circumstances change. So the patient need not worry that they're committing to something that will be here forever. So
Yeah,
lives change and circumstances can change.
correct.
Anything else to comment about the MA's role in this? Any advice for the providers thinking about what the MA does or should be doing?
Yes. Provider wise, if for any chance you see this advanced care planning OPA coming in your view when you open your chart and the MA is done rooming, they are not done rooming. The advanced care planning should be addressed at the time of triage. And these are the questions the MA should be asking the patient before you go in to see them. And we should also be handing the packet just so they're aware of what to be discussed, what's within the advanced care planning. Again, it's really easy to really access the advanced care planning. All I'm doing is clicking on the OPA. So it's a few clicks. So if you can go ahead and just prompt the MA to go back finish the triage. If you're noticing it's becoming an issue at your clinic where it's not just one MA, it's multiple MAs, or maybe you just feel like they need an on-site support of how to complete this workflow, then you guys are more than welcome to reach out to me directly or Selene, or your clinic manager that can arrange anything where we could go and review this workflow with the MAs.
Sounds good. And when you see up by the top left, code not on file, no ACP doc, that is telling us that this needs to be completed. And when the advanced care planning is done, then that changes.
Yes, it will update right now. So currently right now it says not on file because the patient hasn't made a decision on a decision. If the patient brought in a packet, whether it's a post form or the advanced care directive form, the document status will update. What we focus on provider on not we but provider wise would be for them to address the care gap when it does populate, which again will start for the patients who are 65 and older.
Okay, good. Any other thoughts about this?
No, if you have any questions, we do have tip sheets available on how to create a no, update a surrogate decision maker, how to put a code status. If you need extra support, you can again reach out and we could do a one-on-one or remote into the computer to
Right.
assist.
And I'll just conclude by saying we tend to think about this being something that older patients often do, but younger patients have auto accidents, have various circumstances that come up, diagnoses unexpectedly at a younger age, and this can really be a valuable document or information to make available to providers. And it makes it sometimes easier on the family later when this information is thought through. So we really encourage our providers to make an effort to, whatever the patient's age, to enter this information. You just don't know what sort of health problems you're going to have tomorrow or next month or next year. So we encourage completion of this. All right. Thanks, Irma.
All right. Thank you.